Can patients with diabetes but not significant atherosclerosis benefit from Evolocumab? What is the association between lead exposure and cardiovascular disease? Do AI scribes affect charting time and patient volumes? This and much more on today's JAMA Editor's Summary. Hello and welcome to our listeners all around the world. Today is Friday, April 3rd, 2026. I'm JAMA Deputy Editor Dr. Linda Brubaker, sitting in for Dr. Kirsten Bibbins-Domingo, the Editor-in-Chief of JAMA and the JAMA Network. I'm joined by JAMA Deputy Editor Dr. Preeti Malani. And today we're joined by a special guest, JAMA Executive Editor Dr. Gregory Curfman. Greg, thank you for joining us this week to discuss the VESALIUS-CV trial, a presentation at this year's ACC conference. What should listeners know about this trial and the main findings?
Yes, thank you very much, Dr. Brubaker. The title of this study is Evolocumab to reduce first major cardiovascular events in patients without known significant atherosclerosis and with diabetes. The first author is Nicholas Marston. Evolocumab is a PCSK9 inhibitor, and its function as a therapeutic agent is to lower LDL cholesterol levels. Evolocumab is a monoclonal antibody. When evolocumab binds to PCSK9 is less able to interfere with the production of LDL receptors. And more LDL receptors are produced on the surface of hepatocytes, and this results in greater clearance of LDL cholesterol from the bloodstream. So the VESALIUS-CV trial looked at patients without known significant atherosclerosis at baseline before they were treated with evolocumab. And the trial found that even in patients without known significant atherosclerosis, that evolocumab, by lowering LDL cholesterol, resulted in a reduced risk of subsequent cardiovascular events. Now, these patients did all have type 2 diabetes, and therefore these patients were at substantial risk of cardiovascular disease, even though they had no clinical manifestations of atherosclerotic disease before treatment. So even though the patients did not have clinical atherosclerosis, they did have diabetes, which put them at high risk. The reason that JAMA was interested in publishing this paper is that it is the first study of a PCSK9 inhibitor in patients without known clinical atherosclerosis, showing benefit in these patients. So it does open the door for a new type of patient who might benefit from PCSK9 therapy.
Thanks, Greg. That trial is extremely interesting and timely. How do you think these findings are going to change clinical practice?
I think that in patients with high-risk diabetes, that this could conceivably change practice, at least for some of those patients. Even if they have no evidence of clinical atherosclerosis, if they do have high-risk diabetes and they have elevated LDL cholesterol levels, I believe that therapy would be indicated and evolocumab would be one therapeutic choice among others that could be considered for these patients.
Thanks, Greg. JAMA Senior Editor Dr. Phil Greenland co-authored an editorial with Dr. Lloyd Jones. They reiterate that evolocumab added to statins reduces major cardiovascular events in high-risk patients without prior heart attack or stroke. They emphasize that long-term safety and cost-effectiveness are uncertain, and treatment should be individualized while adhering to current guidelines. Greg, thanks for sharing this information with our listeners. Hope to have you join us again soon for another JAMA Editor's Summary.
Thank you for having me, and I'd be happy to join you again.
Well, let's move on to the next JAMA research article, which is about lead exposure and cardiovascular disease. Lead exposure has declined markedly during the past 50 years thanks to regulation and removal of lead from gasoline and restrictions on lead in paint and other consumer products. However, lead exposure remains a significant global risk, especially in low and middle income countries. Lead is found in old paint and other products, contaminated water, and from industrial activities. Lead in neurotoxicity is well described in children, and now its role in cardiovascular disease among adults is increasingly recognized. The Global Burden of Disease 2023 lead collaborators analyzed data from more than 42,000 U.S. adults in NHANES from 1988 to 2013 and included more than 1,700 deaths from cardiovascular disease. Bone lead levels were estimated using blood lead values, participant age, and cohort-specific exposure histories. Primary outcomes were lead-attributable cardiovascular disease mortality, years lived with disability, years of life lost, and disability-adjusted life years, stratified by age, sex, year, and geographic location. The authors reported that higher bone lead levels were associated with significantly increased cardiovascular mortality risk. They also reported that lead was the 8th leading risk for global mortality and the 2nd leading environmental risk. All of this is important since lead exposure is preventable.
Dr. Lanfear's editorial highlights that environmental lead exposure is a major contributor to coronary heart disease, responsible for nearly 30% of global mortality. Clearly, clinical care alone cannot counteract these upstream environmental risks. Population-level strategies for prevention are needed.
We also published an article this week by Dr. Rottenstein and colleagues who take a closer look at artificial intelligence-powered clinical scribes. These authors investigated if adopting AI-enabled scribe technology could decrease time spent on the EHR, including documentation, and time spent outside of scheduled hours or on unscheduled days, along with weekly visit volume. This was an observational study using a longitudinal cohort that spanned 5 major U.S. academic health systems from 2023 to 2025. More than 8,500 ambulatory clinicians participated, including attendings, advanced practice clinicians, and residents. About 1,800 of them adopted AI scribes. The others served as controls, so again, this was not randomized. Researchers measured time spent in the EHR, documentation time, and ambulatory visit volume, comparing before and after scribe adoption and adjusting for practice and individual differences. The authors reported that adopting an AI scribe was associated with modest improvements. Clinicians using AI scribes spent about 13 minutes less in the EHR and 16 minutes less on documentation, and for every 8 hours of patient care, the authors observed a 3% drop in total EHR time and a 10% decrease in documentation time. There was also an observed increase in clinical productivity, about a half an extra patient visit per week per clinician. EHR time outside of work hours did not appear to change significantly. They observed that primary care clinicians, advanced practice clinicians, female clinicians, and those who used AI scribes in more than half of their visits experienced the greatest effects.
Editorialist Dr. Tierney and colleagues emphasize that evidence for patient outcomes and equity is still emerging, and risks like worsening disparities or trust issues remain. The editorial calls for research beyond workflow metrics to focus on quality, equity, and real patient impact. Preeti, let's turn to the JAMA research letter from this week.
Sure, Linda. Medicare is facing rising costs as the demand for semaglutide injectables like Ozempic and Wegovy grows. In this study, Dr. Duset-Zina and colleagues compared projected 2027 spending under 2 pricing models. The new Balance Voluntary Agreement, which prices these drugs at $245 per month, versus the Inflation Reduction Act's negotiated maximum fair prices, which is $277 a month for Ozempic and $386 for Wegovy. Using 2024 Medicare Part D data, researchers found that with balance pricing of $245 per month, Medicare could save an estimated $933 million and treat an additional 550,000 beneficiaries, which represents about 4.4% of the 12.4 million eligible under expanded obesity coverage. If usage doubles or prices fall further, up to 3.6 million could be treated at no extra cost. The authors conclude that lower prices could greatly expand access to obesity treatment for Medicare beneficiaries.
In the JAMA Viewpoints this week, Dr. Holt considers the issue of breast density masking in routine breast cancer screening. She proposes how to overcome the reduced sensitivity of mammography in women with dense breasts and ensure they get access to supplemental imaging. In another viewpoint, Dr. Yang and colleagues consider whether U.S. healthcare is truly bridging the care quality chasm. Their viewpoint examines whether decades of technical process have matched the bold vision for safe, equitable, and patient-centered care. The authors urge more structural transformation to bridge the gap and improve healthcare quality.
In their viewpoint, Dr. Gassoyan and colleagues tackled the CMS balance model, a new effort announced to expand access to obesity medications and lifestyle interventions for Medicare and Medicaid beneficiaries. They explore whether standardized coverage and negotiated drug pricing can address persistent barriers like cost and access and improve obesity-related care for patients and clinicians alike.
There's also a new perspective article by Dr. Adler-Milstein and colleagues. They spotlight how the growing dominance of electronic health record vendors shapes how artificial intelligence tools are integrated into hospital workflows. Preeti, what's new in the JAMA Clinical Reviews and Education section this week?
Well, Linda, this week we have 2 JAMA guidelines synopses. The first is by Dr. Vora and colleagues about the management of acute coronary syndrome. The authors reflect on these guidelines, including aspirin and statin use, released in 2025 by several prominent medical associations, including the ACC and the AHA. And Dr. Winchester and colleagues published their clinical guideline synopsis on perioperative cardiovascular medication management for non-cardiac surgery. They summarize recommendations for adult patients undergoing non-cardiac surgery, including medications like statins, antiplatelet agents, and beta blockers from a guideline published in 2024 by the AHA and ACC.
Don't miss the latest JAMA podcasts. JAMA Associate Editor Dr. Margaret Wheeler and author Dr. Auerbach review absolute iron deficiency with or without anemia. They discuss the causes, diagnosis, and best practices for oral and intravenous iron therapy in adults. Let's listen to their conversation.
So earlier, you spoke a little bit about the signs and symptoms of iron deficiency. Tell us a little bit more about those.
Okay, so there are a bunch, but by far, the most frequent symptom is fatigue. And that's a problematic symptom because fatigue is ubiquitous. We all have fatigue. We have fatigue when we work. And virtually every disorder is associated fatigue. So it's too nonspecific. And although the doctor should ask about it, I don't think you can hang your hat on it. Brain fog, difficulty concentrating, is another relatively disturbing symptom of iron deficiency. But 50% of patients with iron deficiency either have pagophagia, or a pathological craving for ice, or less commonly other substances, or restless leg syndrome, a disorder where you cannot keep your legs still in bed at night and have to get up and walk around because of the uncomfortable sensations. When it gets much more severe and the anemia becomes dangerous, now you start to get hemodynamic symptoms like shortness of breath at rest or severe dyspnea on exertion, and in its most extreme forms, cardiac ischemia or decreased blood flow to the brain.
And JAMA statistical editor Dr. Roger Lewis and Dr. Dean discuss test-negative study designs for evaluating vaccine effectiveness in a JAMA Guide to Statistics and Methods podcast. Let's hear a bit from them.
So what are the limitations of the test-negative design?
A key limitation relates to the test itself. It's got to be a good performing test, and if it's not, then you're going to misclassify either your cases or your controls. And that's different from a case control study, because if you have a case control study, okay, you have someone who really has flu, for example, and they happen to test negative, well, they just get dropped from the study. They're not included anymore in the analysis. But in a test negative study, they become now the controls. So there's like more chance for that type of misclassification. On the flip side, we also observed this thing where because of co-infections, like during the period when COVID was extremely prevalent, and you could imagine someone had a co-infection where their symptoms are due to some other thing, but they happen to also be infected with SARS-CoV-2, well, then that can also lead to another type of misclassification. So they can go both ways.
And as always, there's a lot happening in health news. The JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
Well, that's a wrap for this week's JAMA Editor's Summary. Thanks, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani, Dr. Greg Curfman, and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.